Please welcome Dr. Frauke Musial from Norway.
Yeah, it's on. Okay, wonderful. Well, thank you so much. Actually, well, this is a laser, and I go back like this. No? How do I go back like this? Okay, the original title that you've seen in the program is Homeopathy as a Whole Medical System. And throughout the day yesterday, I have decided to actually change my talk completely and talk about research in homeopathy before the mechanism of action are understood, because I think that's really what we're talking about. And one thing that I have to tell you is I'm really fond of the randomized, double-blind, randomized, controlled trial. And I will try to explain why. And besides all the fascinating things that we have heard today, I think I'm actually head of the quantitative part of research at NAFCAM. So I think the research methodology that we use is actually a wonderful set of tools. It's just important to find the right method for the right question. I think that's the point that we're talking about. So I'm trying to introduce some of the research strategies that we use in clinical trials and explain also to you why some of it is so difficult to apply to homeopathy, because I think that's important to understand. Okay, yeah, that might be a little bit helpful, yes. So I thought we really have to go back to the scientific method. So in bioscience, we always talk about empirical research. And empirical research means a measurement of observations. That's what you do. You observe in the broadest sense. You can also observe in the way the effects of quantum physics. You can also observe in the way the effect of nanoparticles. It's just a measure of technology very often. So in basic science, we also observe. But we observe with a high effort in methodology. The restriction that we have in the empirical research is that we're limited to problems which can be principally tested. And that's part of the criticism that was here. Is that really the method that we need? Yeah, that can be discussed. If you go into theoretical research, it's perfectly fine. But if we go into bioscience, very often, or as a general rule, we are bound to do empirical research. Yeah, and exactly. It must be principally testable. That's the requirement. And one example. Reiki healing. Reiki healing means many patients report positive experience with Reiki healing. There's actually no doubt about that. And if you look at the assumption, there's a very principal assumption, and that says the individual is being connected through the Reiki procedure to universal life energy. And at this point in time, it may be true or not, but we are not able to test it or to measure it. So that has as a consequence that Reiki is seen as a pseudoscience and esoterical. But there's another assumption that you can make, and that is Reiki has positive, I don't know, does everybody know what Reiki is? It's healing, it's a form of healing. Reiki has positive influences on patients. Well, that is principally testable. You can measure subjective feelings, well-being, symptoms, and biomarkers, etc. There's no question that you can do that. This is a metaphysical question, and this is an empirical question. And I want to be understood right. This is a non-judgmental, what I say. It's non-judgmental. You can discuss metaphysical questions. I think it's important to do that. But when it comes down to science, when I go into my office, I have to have an empirical question to work with. Yeah, the empirical method. It is a tool to investigate observations such as behaviors, feelings, biomarkers, and so on. And the aim is, and that again can be criticized, and that is there is a principal problem in it, is to find out how one phenomenon, for example, a treatment, influences another, for example, inflammatory marker. And there's a slight problem in here because it assumes there's a causal relationship between the two. Causality. That's sort of the point here. So we often talk about factors influencing something. So we have a phenomenon, and then we have a postulate another phenomenon, or try to describe it, which influences that one phenomenon. That is, very simply speaking, the basis of empirical science. And it all comes back, or many of the things that we talk about now, the procedures that we use, comes back to Wilhelm Wundt's principle of isolated variation. Well, I'm by training a psychologist. I studied biopsychology, which today would be neuroscience, and I have been tortured with Wilhelm Wundt for many, many years. So what he says is that in an experiment, you have to identify the relevant factor. That could be, for example, that naloxone binds to the opiate receptor, many, many other things. But you have to identify that one factor that influences your phenomenon. And only this factor is varied. So that could be different dosage from high to low to placebo, whatsoever. And all other factors, and that's the principle of experimentation, are held constant. So they don't systematically or unsystematically vary with the variation of your interesting factor. And that's exactly the question that came up after the last talk, where how do you control these patients? You can't. So there we have a problem, very obviously. Okay, so with regard to trials that we do, trials that relate to Wilhelm Wundt's principle of isolated variation are explanatory. They want to explain a phenomenon, right? They want to give us a cause why this phenomenon happens. They explain if and especially how an intervention works. They aspire homogeneity of everything what you do, homogeneity of the sample, for example, right? You have highly selected patient groups if you work with explanatory trials. And they have a high internal validity, which we love in experiments, of course. And they investigate cause-effect relationships. And that typical example for that, as I said, would be the randomized controlled trial. And as a researcher, if you have conditions like that, it's a dream. So randomized controlled trials try to control systematic errors because they don't want, the only thing they want to vary is that interesting factor, the principle of isolated variation. So this is why there's a randomization. So you don't have that asymmetric self-selection of patients. You would have to randomize patients. So you just use chance in order to get the same population in both of all of the groups that you use. You use blinding because we know that the expectations a patient has, but also the expectations that somebody who runs a trial has, influence the outcome. So the ideal thing is everybody's blind. Nobody knows everything. The patient's blind, the experimenter's blind, right? And so on. So inclusion criteria, I have said something about that. So what you get is well-controlled experiments with credible statistical results. And this is something I'm not sure that you can read that. I say that's German. Die homöopathischen Kochsalzversuche zu Nürnberg von einer Gesellschaft der wahrheitsliebenden Männer veröffentlicht durch Dr. Georg Löhner. This is the homeopathic Kochsalz, this was Natrium muriaticum, D30, from Nürnberg, from Society of the Truth-Loving Man, published. The interesting thing, and that is, it's the first double-blind, randomized, controlled trial, and it was a homeopathic trial. The homeopath invented the double-blind, randomized, controlled trial.
They also invented the multi-center double-blind. The first multi-center double-blind is also.
Yeah. So homeopathy has a long tradition of empirical science. Not very many people know that, but that's quite interesting. So go back to home. So that's sort of the background of the RCT. The whole medical system, that could be, what are whole medical systems? That is systems of medicine that are very complex. For example, traditional Chinese medicine, Ayurveda, Kampu, Native American medicine, but also homeopathy, anthroposophy, and integrative medicine is the sort of more modern sort of whole medical systems. And they have a problem with regard to the RCT. They are potentially synergistic, multimodal, and complex interventions, aiming at symptom amelioration and psychosocial and behavioral changes, so very complex. And they're often very dependent on the patient-practitioner relationship. They often deal with patients with chronic diseases and with multiple pathologies. patients in whole system trials very often have different age, gender, socioeconomic status, and so on. They have a different personality. They have different lifestyle. They are multimorbid, and they have different treatment preferences. For example, they are strongly for or against homeopathy. This is why you cannot randomize them. They made different treatment experience. They hear different music, and so on. So you can actually characterize all possible levels how these patients can be different. So if we go back to our principle of isolated variation, where you have one factor influencing another, that is the more complete picture that you have. And then, if you go back to homeopathy, you see what happens. The thing that you look at is a remedy. That's what I heard these last 1.5 days. But if you look at this, that's a very blurred picture. And then, of course, that has also been discussed before. These factors may not just be additive, they may interact very complexly with each other. So the sum of these factors may be something different than just the sum. Yeah. Okay. So what you can easily see is that if you run an explanatory trial under these conditions, that will change the validity of the treatment model. And that's what you said yesterday, and I thought that's the core point. The validity of the treatment model, that's something that you have to preserve when you do research, clinical research. We're now sort of tying that thing down into clinical research under these conditions. And the problem that you also have in these trials, if you look at all these factors, you need extremely large sample sizes in order to determine one factor, because it's so complex. And that's a discussion that we just had. The study was powered enough to identify the interview, but maybe not powered enough to identify the remedy. I don't have any opinion. I'm not a homeopath with regard to remedies, but I think the answer to that is, if you have a smaller sample size indicating the interview, it's hard to argue against that. But an argue against it would be the interview cannot play a role in animal experiments. Okay, the NAFCAM model. The NAFCAM model is something we work with because, of course, the Norwegian taxpayer pays my salary, so we have to justify in a very good way why he or she should pay my salary. So the NAFCAM model describes basically the kind of research that we are forced to do when we do research on CAM. It's not specific for homeopathy, it's specific for CAM in a way. So this is a traditional research model where at some point you go into RCTs. That's the pharmacological model. You have a screening of chemical substances, you have phase 1, 2, 3 trials, then you have a gatekeeper. So by the time you go into clinical practice, you have a pretty good idea what happens, and you have also a pretty good idea about the safety of your drug, right? I think there's probably bias in publications and so on, but you have an idea. What are we faced with? That's the NAFCAM model for research that we use. Well, we face the fact that clinical practice is a fact, and we actually don't know much about this. That's the problem that we face in CAM. The intervention have often been practiced for generations. Clinical practice is a fact. So we're confronted with a situation where, without having a good idea what's going on, we have the therapies in practice. So we stand here. We know often a little bit about safety, but just from experience, not from systematic investigation, and from clinical experience. So we know something about that. But the biological mechanism, we mostly don't know anything. And on top of it, most of these interventions are very complex, as I have just pointed out to you. So this action, this situation here, component efficiency and mechanism of action, what we say component efficiency is which part of the treatment works. For example, in the example that I just had, is it the remedy or the interview? That would be the question, yeah? And the mechanism of action, that's the discussion that you had in the talk before me, is it nanoparticles, is it quantum mechanics? That would be the mechanism of action. But we don't know. The problem is, if you go from here to here, that may induce several misunderstandings in the interpretation of the trials. So that is the core question, in my opinion, why the RCT, or why the RCT has been so criticized so much. Okay, going back to whole medical systems, you have particular treatment modalities, you have specific therapies, patient-practitioner interactions plays a major role. Most disease interventions are combined with techniques for changing patients' behavior. You often have also specific diagnostics in TCM, for example, and in homeopathy you have the homeopathic interview, so there's also methods of diagnostics that are specific for that system, and you have theories on mechanisms. That's specific to all whole medical systems, that they have theories of mechanisms that are not necessarily derived from conventional physiology. Okay, so what happens in this research model is that your biological mechanism is actually substituted with theories of mechanisms that are derived from the whole medical system itself. And then, on this basis, an RCT is performed. And I will show you an example. Is that clear? Yeah? So the RCT is based mostly on the pharmacological model, where you have a very clear mechanism. It's clearly described. You know it from basic science. And here you have you use a theory that in the whole medical system and apply the RCT. And that can be quite misleading. And this is why the RCT has been criticized so much. Okay. So problems in chemists, the biological mechanism is often not clear, safety set is somewhat known, you have no clear hypothesis. And then we come to the core problem. That's sort of the heart of the issue. Many people who don't do experiments think, or don't do that very, very often, think the core issue in an experiment is a treatment group. It's not. It's your control groups. Your treatment group is often very clearly defined, but you always measure, that's the principle of a trial, the effect of the treatment group in comparison to a control. And very often the issue is the control, not the treatment group. And then you have the problem that your trial will not give clear results because the difference between treatment and control is not clearly defined. So the issue is it is very difficult to develop an appropriate control if you're not clearly informed about the mechanism. And I would give you an example from acupuncture research to explain what I mean. Let's say you have a fictitious drug trial for a sleeping pill. This would be a classical RCT. You have a Verum group that gets the highest dose. Then you have another Verum group that gets somewhat smaller dose. And then you have a placebo group that gets no dose. This is a double-blind trial. Nobody knows. The patients don't know. And the person giving the pills also doesn't know. And oops, you measure sleep quality. And then you have a difference here and a difference here. And it's clear these differences give you the effect of the drug. Right? So that's clear because here, what's in here? In here is, you see, there is a little effect of the placebo pill, even though there's no substance in the placebo pill. That's always there. You always get an effect with your placebo pill. But that's expectation, that's a positive attitude, that's maybe the patient relaxed. These are all so-called unspecific effects. And they can be quite large in trials. So the real drug effect is always between this group and the two other groups that you have well defined. I'm now showing you a trial from the big German acupuncture trials. And what I would like to say is this has been a wonderful trial. It has been extremely controlled. It has been, the authors or the people planning the trial have gone through lengthy efforts to make this a very, very good trial. That consensus conferences around the points to kneel and so on. This has been one of the best controlled trials ever. Look at the results. So here we have the conventional therapy group. That should be sort of your maximum Verum, right? And we see that in the back pain condition, probably almost 30% of the patients improve. So clearly, from the setup, that should be, after all we know, your gold standard, your best group. And then there was a Verum acupuncture group, and that Verum acupuncture group was actually almost 48% of the patients, so that was better than your gold standard. And then you have a sham acupuncture group. So that is actually what would be comparative effectiveness in the NAFCA model. So you have two treatment systems, you have two types of interventions, and you can say that intervention is better than the other. There was a significant difference here. Now you have sham acupuncture. And now you have a problem. Because you don't know what that is. If you interpret that as a placebo, that difference was significant, that difference wasn't. If that is a placebo, then of course you have a very strong placebo effect. And that's but nobody talked about this effect, that both conditions actually were better than conventional therapy. And it actually turned out that if you combine all the trials that are credible on sham acupuncture, that you do get a difference between Verum acupuncture and sham acupuncture. So I think what I would like to point out to you is you really have to know what your control condition does to run an RCT. So the problem in CAM is that the biological mechanism is often not clear. So your research strategy is hard to pick. So if you want to have minimal acceptance, then I think you have to do research on the safety status of what you're doing. Because then at least you can argue it's not dangerous what you do. So the systematic investigation of your safety, of the safety status of what you do, I think is mandatory. I think it's important. After everything I have experienced, the societies are usually very interested in systematically evaluate and estimate the safety status of what they do. If you want to have clinical acceptance, then system effectiveness, I think, is a good way to look at. So what does your whole package do? What does your model do? Right? Here, I'm not so sure. You have to have a specific biological mechanism before you can actually go into component efficacy, before you can investigate that. So if we want to look at this here with regard to homeopathy, what happens, only if, sorry about this, only if you really know this, you can actually go and perform a classical RCT. You have to be sure. Okay, so if you don't have that, you have to stay with comparative effectiveness. And there are instruments to do that. All I have is a bag of instruments. I'm a quantitative researcher, and all I have to do is to pick the right instrument for the right question. So if I cannot run explanatory trials, then I have to run pragmatic trials that go for effectiveness. And that is the question whether an intervention works in real life. And that is also a question that aspires diversity. If you want to know whether an intervention works in real life, you want to have different centers with different patients, with different settings. Because what you want to do is exactly what Dr. Fischer pointed out. You want to know how valid is your model in different circumstances. That also calls for very, very large trials, but it gives you a robust measure of how good your model, your treatment model is. And it has a very high external validity. So these go for the principle of isolated variation, that these trials can give you an idea about causative causality. That's the whole package. You cannot say anything about causality here. But you can say something about model validity. Okay, the RCTs give inconclusive results. That's what we heard yesterday. Cohort studies and observational studies give consistently results in favor of homeopathy. And that supports why you should go for system effectiveness. If I were to apply the Reiki example to homeopathy, then I say they're very interesting basic science assumptions, but they're not yet testable. But the assumption that homeopathy has positive influences of patients, that is testable. And I would support to do that. Yeah, I know, I will be finished soon. I started a little bit later. If you look at the evidence of hierarchy, then it's not so bad if you run these trials. I'm not so sure why you would want to stay with this, because a level 2A evidence is quite high. And all the evidence system, and that is observational studies and cohort studies. So these trials just go for efficacy, but these go for effectiveness. And if you want to clinically accept, it's perfectly fine to go for these trials. And that's no matter what kind of categorization you choose, it's always reasonably high. So if you go for evidence-based medicine, they have a very high standard. One last remark. I heard a very impressive talk yesterday about creating a safe situation just because you're trained as a homeopath. That has an influence on patients. And I would like to ask you something. Many of you have practiced in homeopath. To how many of you have patients revealed a trauma? Hands up.
Sorry, please.
A trauma? A trauma. How many of these patients are in psychotherapy and have not revealed that trauma to their psychotherapist? Yeah. Very often that happens. See, and that's so interesting, that patients reveal trauma to the homeopath. And if you look at the literature, that's actually the health benefits of revealing a trauma that has been hidden are enormous. And there's a vast amount of literature on that. So just to give you an example, this is very complex, but the different elements can contribute in a different way, and it might be worth looking at some of the elements. Now I'm finished. Oops.
Thank you very much. We have time for one question, so please.
Thank you. Very interesting. But if we now take a common RCT for a conventional medicine, and we put it in a wholeness conception, then we can see that it works. It gets an effect. But when put into wholeness, we have also to consider the negative effects on the patient, the side effects. And that is not in the RCTs. So, and that is probably a major problem, because I have been looking thoroughly through the development of disease in Sweden, and it's no question that cancer is rising with about 4% each year. We have an explosion of dementia, of the Alzheimer's and such diseases. We have a steady rise of psychiatric problems. And why? We have to look broader than just to see that there are an effect on the RCT for conventional medicine.
Is there a question?
What do you say about that?
Yeah. I would say that's exactly my point. You shouldn't go, if you don't have that isolated question, you shouldn't go for an RCT. But that does not make the RCT a bad method. It's just you have to pick from a spectrum of methods, you have to pick the method that's appropriate for your question. And the RCT will not answer any question on the whole medical systems. But side effects and deteriorations, that you would not answer with any of these questions at all. For that, you would have registries. They look for safety. In an RCT, that's actually not a good measure to look at safety, because you would put large sample sizes as risk. So that's definitely not what you would do. So if you want to look at safety, you need to register your practice. If you want to look at safety in other aspects, you need to have registries. where you actually register what happens and to document your adverse events. So if you look for adverse events, all these methods are not applicable. You should monitor them as well, but you should, if that's your goal, it's not the right method to use. So just clearly state that.
Thank you very much, Dr. Frauke Musial from Norway.